Welcome to this new Gentian webinar in our Calprotectin webinar series. My name is Paula Lindner and I'm the Scientific Product Manager at Gentian, responsible for the Calprotectin assay GCAL. Today I'm very excited to talk about the use of Calprotectin as biomarker focusing on bacterial infections. Thank you for joining me today. I want to start to give you a small introduction and background information about the protein Calprotectin. Calprotectin belongs to the S100 family of proteins, a superfamily of calcium-binding proteins, which are essential components of the immune response. Calprotectin is a heterodimeric complex of two S100 proteins, S100A8 and A9. Synonyms for the heterodimer calprotectin you will also hear regularly are S100A8A9, but also myeloid-related protein MRP814, calculatin A and B, and its original name on its first isolation was major leukocyte protein L1. Calprotectin is mainly expressed by phagocytes like neutrophils, monocytes, and macrophages, and it makes up a large proportion of the cytosolic proteins in these cells. It is a key alarmin released in the first-line immune defense as response to infections and non-infectious inflammation. The antimicrobial activity of calprotectin is mediated by the sequestration of zinc and manganese from the bacteria environment, and thereby it's starving the pathogens. And calprotectin is also a pro-inflammatory transmitter, mainly by binding to two receptors, RAGE and toll-like receptor 4, driving the procession of inflammation. Importantly, calprotectin is consistently expressed and stored by neutrophils, meaning there is no need for de novo synthesis before it's released in inflammation. And this enables a very fast and direct upregulation in the inflammation reaction, which is also why calprotectin has been shown to be an early and valuable biomarker in a whole range of inflammatory conditions, including bacterial infections. So let's take a look at some of the data on calprotectin as biomarker. First, I want to highlight a simple experiment analyzing the kinetics of calprotectin compared to PCT and CRP. Healthy volunteers were given endotoxin shot to mimic the reaction to a bacterial infection, and the time course of the biomarkers was followed. As you see, calprotectin levels start to rise already after 2 hours and peak around 4 hours, while PCT peaks at 8 hours and CRP only after 24 hours. Also, the normalization of biomarker levels is fastest with calprotectin, making calprotectin a very early and a direct marker of the inflammatory reaction in bacterial infections. So let us now take a look at some results published regarding calprotectin as biomarker in the diagnosis of bacterial infections. First of all, calprotectin has been shown as a reliable biomarker for diagnosis of bacterial infections reported in this study using the Gentian GCAL assay. Since calprotectin levels rise in response to bacterial infections, increased levels show a clear distinction toward a healthy control group. But more importantly, the study also demonstrated that calprotectin can be used as a discriminator between bacterial and viral infections, because calprotectin levels mainly increase in bacterial infections. So elevated calprotectin levels can be used to discriminate between viral and bacterial infections with a cutoff of 2.37 mg per liter reported here. Interestingly, in this study, it was also reported that calprotectin is increased in mycoplasma infections, in contrast to PCT and HPP, as you see in the work curves to the right. Calprotectin can therefore be used to differentiate between mycoplasma and viral infections as well, a diagnosis which is normally very hard and based on longer follow-up. So increased calprotectin could give an early indication to progress in the diagnostics of mycoplasma infection by X-ray or CT. Another important differentiation lies in the infection versus sterile inflammation. As calprotectin is increased in bacterial infections, it can be used to differentiate towards other sources of systemic inflammation with high sensitivity and specificity, as you see in this graph where the authors described calprotectin as discriminator between bacterial sepsis and non-infectious systemic inflammation. This distinction between inflammation caused by bacterial infections and non-infectious inflammation was also reported comparing calprotectin levels in bacterial sepsis versus viral inflammation after trauma. As you see in the levels of sepsis and trauma to the left, calprotectin is able to differentiate between these two patient groups, while PCT was also increased in trauma patients. So to the right you see the corresponding ROC curves where only calprotectin could be used to differentiate between bacterial infection versus trauma. And importantly, calprotectin has also been reported as suitable diagnostic marker in neonates, since calprotectin is part of the innate immunity given from birth. And calprotectin levels were strongly increased also in neonatal sepsis. And the diagnostic accuracy of serum calprotectin was also reported to be greater than that of the traditional markers of sepsis, with a sensitivity of 89% and a specificity of 96%. So in conclusion, serum calprotectin is an accurate marker of sepsis also in newborns. And finally, this very recent study confirmed the diagnostic performance in young children under the age of 3 years, where serum calprotectin could differentiate between bacterial infections and viral infections. They conclude that also in this age group, calprotectin can give substantial added value in the early management of a child with fever as an accurate biomarker in distinction between bacterial and viral infection. So in the next part, I want to highlight some results looking at calprotectin as prognostic and risk marker in bacterial infections. Here we will look at the results of calprotectin as prognostic biomarker, also from some of the same papers as in the first part, focusing on the diagnosis. This first paper I want to highlight showed that calprotectin levels can be a predictor of bacterial infections and the need for antibiotic treatment. As you see in the table, with a cutoff of 3.4 mg per liter, calprotectin can be used for diagnosis, hence the same day the antibiotic treatment is started. But with a cutoff of 1.8 mg per liter, calprotectin was even able to predict the need of antibiotics one day before, which means the antibacterial treatment could be started earlier. And also please note this table includes results from all possible, probable and confirmed infections only. While looking at the same analysis, only including confirmed infections, the performance of calprotectin for predicting the antibiotic treatment was even improved, with a cutoff of 1.6 mg per liter and a specificity of 93%. Hence, with these results, they showed that calprotectin can be used as a prognostic marker, potentially guiding an early start of treatment and thereby avoiding severe events following the infection. Based on these promising results, we have built a health economic model to estimate the cost effectiveness of analyzing calprotectin for early detection of bacterial infection and thus the earlier start of antibiotic treatment compared to other diagnostic biomarkers. So here you see the decision tree model, which was used to create a base case scenario where calprotectin is employed predictively compared to the comparators used diagnostically. Taking this base case scenario, the results show that predictively measuring calprotectin in an ICU setting reduces total costs by approximately 13,000 to 18,000 euro per patient, overall mortality rate by 11%, and mean length of stay in ICU up to 2 days and general ward up to 8 days. So by being able to start antibiotic treatment earlier with a predictive calprotectin analysis, not only can the hospital reduce its costs and optimal use of resources like ICU beds, ventilators and healthcare workers, but also improve the patient outcome. Next, I want to show you more results of one of the already earlier mentioned studies, where you can clearly see the increase of calprotectin levels based on disease severity, from controls to serious sepsis, severe sepsis, and finally septic shock. And On the right side, you can also see the increase in calprotectin levels in survivors versus non-surviving patients. And corresponding to the increased levels with mortality, if you look at this ROC curve, it shows the performance of calprotectin to predict mortality, which was even higher than the classical MET score for sepsis. Again, showing the potential to being able to start an earlier treatment with predictive calprotectin analysis. And these increased levels of calprotectin were also confirmed in this report, where you can see the increase in the total cohort of septic shock patients, but also the further increase in non-survivors, allowing for risk stratification for the clinicians. And also in these ICU patients, where the authors reported a predictive value for 30 days mortality with 80% sensitivity, while PCT was not able to predict mortality in this ICU cohort. Another important aspect in patient management is the early decision in the emergency department where to transfer the patient. Calprotectin was described as a valuable aid in the management of these patients presented to the emergency department, where it was the only biomarker compared to PCT and CRP on the right side, with significantly increased levels in patients transferred to ICU or HDU compared to patients transferred to the ward. Hence, calprotectin levels can be used as aid in the decision-making if it's necessary to transfer patients to the ICU. If we look at the ROC analysis for transfer to the ICU, it showed high area under the curve for calprotectin, significantly higher than PCT and NLR, while notably the delta SOFA score did not differ between patients transferred to ICU or wards. Interestingly, patients initially transferred to ward units who were subsequently transferred from ward to ICU within 12 to 72 hours from presentation, they had initial high calprotectin levels. So these findings indicate that a stable patient who does not require ICU transfer from the emergency department, but who has a high calprotectin level, may have an increased risk for subsequent requirement of ICU transferal. Finally, I want to show these survival curves, where you can also clearly see the predictive value of baseline calprotectin levels at ICU admission as predictor of mortality. You see these two Kaplan-Meier curves either using the 50% percentile with 2.7 microgram per milliliter as a cutoff, or the optimal cutoff of 2 microgram per milliliter, which gives a clear separation between the survival curves. Coming to the final chapter, where I want to highlight some results looking at calprotectin as biomarker in localized bacterial infections. There have been a number of studies investigating the diagnostic use of calprotectin measured in synovial fluid for periprosthetic joint infections, which is a serious complication of hip and knee replacement. There have actually been 3 meta-analyses reporting pooled sensitivity and specificity over 90% for calprotectin measurements in synovial fluids from 5 to 8 studies analyzed in total. Interestingly, one of these studies also directly compared blood calprotectin and synovial calprotectin and found high correlation between the blood and synovial calprotectin with an R of 0.84. In that study, they analyzed 195 patients undergoing primary or revision hip and knee arthroplasty, of which 45 had confirmed chronic PGI. They could show high sensitivity and specificity in synovial fluid measurements, but also in measurements of blood. Here you can see that the cutoff of blood calprotectin with 1 mg per liter was lower than for synovial fluid with 1.5 mg per liter, but with very similar performance. They also showed that calprotectin had a higher diagnostic performance compared to other inflammation markers. There is one more publication I want to show you looking selectively at serum calprotectin in PGY diagnosis. As the previous paper, they reported a good diagnostic performance of calprotectin with high specificity of 91% and good sensitivity of 81%, confirming the value of calprotectin measured in blood samples for the diagnosis of this localized infection. So in conclusion, blood and synovial calprotectin can be a useful and inexpensive tool to diagnose chronic hip and knee PGI. A high correlation between blood and synovial calprotectin indicates that in cases where it's not possible to collect synovial fluid, blood can be used instead with a good performance. So to sum up, why should you use calprotectin in bacterial infections? The first advantage lies in the differentiation of bacterial infection from both viral but also other sterile inflammations. The growing concern of antibiotic resistance calls for the cautious use of antibiotics. Proper prioritization and optimal use of resources can help tackle this issue. By implementing appropriate diagnostic methods and correctly differentiate from viral infections and other inflammatory sources, we can ensure that antibiotics are prescribed only when necessary, reducing the risk of resistance and improving patient outcomes. The second advantage lies in the timely detection of infections, which is crucial for effective patient management. Hospitalized patients, like in the ICU or post-operative recovery, are at higher risk of developing infections. Regular surveillance and prompt intervention can improve patient outcomes and reduce the burden of severe infections. In addition, some infections may present as localized without significant systemic inflammation. Recognizing these infections early is essential to prevent their spread and potential complications. Calprotectin can aid in managing localized infections effectively, also avoiding unnecessary hospitalizations. The third advantage lies in risk stratification using calprotectin. It can play a vital role in identifying patients who require early initiation of antibiotics to improve outcome and also reduce antibiotics use overall. Accurate risk stratification enables healthcare providers to make informed decisions regarding the level of care and appropriate treatment interventions. By incorporating calprotectin in the clinical assessment and risk assessment tools, it can aid the decision whether a patient requires ICU-level care, can be managed in a general ward, or can be safely discharged with appropriate follow-up. In particular, identifying patients at risk for sepsis and severe events is crucial for early intervention and improved outcomes. Utilizing calprotectin can help with identification of patients who require closer monitoring, early initiation of appropriate antibiotics, and target interventions to prevent the progression to severe sepsis or septic shock. In conclusion, the differentiation and management of bacterial infections can be improved by incorporating calprotectin measurements, prioritizing resources and antibiotics, distinguishing bacterial and viral infections, identifying infectious from other inflammatory sources, early detection, monitoring vulnerable patients, risk stratification, and guiding treatment decisions are key elements in providing optimal patient care. Thank you very much for your attention today. You will find more information and background articles on calprotectin and the GCAL assay on our website, and please feel free to contact us directly as well.